It's a pleasure for me to introduce our first speaker, Dr. Parasanada, who is a geriatrician and has dedicated herself to working in both community and academic settings. She provides care to older adults at the Over 60 Health Center in Berkeley, California, and at the University of California at San Francisco Care at Home. And she has worked extensively internationally, and especially in El Salvador, Kenya, and Mexico. And she has received national and international recognition and acclaim for her research on loneliness, on the health and well-being of older adults. So it is my pleasure to introduce Dr. Carla Parasanada, who will talk about the health effects of loneliness in our communities, making an impact on a growing pandemic.
Good morning. It's fantastic to be here and to have such a great community that's interested in this topic. As Vicki introduced me, I am a geriatrician. My main work is actually in caring for older adults, and really my research comes from the work that I see in my own patients. So though I do research, I would say that my main love is actually seeing patients, and I'm a clinician. So this work is, again, because I've seen a need in my own patients and in my own community and know that there's something that we can do. Now, the title about a pandemic, it's really, if you think about the word epidemiologically, pandemic really refers to something that's spread across communities and affecting all people. So it's not that loneliness is contagious, but rather it's trying to bring awareness to the fact that this is really a public health crisis internationally and something that we need to take into account. So what we're going to do today is that we're going to talk about the different concepts of loneliness and social isolation so that we can understand that they're actually distinct topics. We'll talk about the effects of loneliness on health. We'll think about different strategies for addressing loneliness. And then lastly, I want to talk about different organizations, both in your community here, nationally and internationally, that are working on this topic. So let's start with 3 stories. And again, as I said, I'm a clinician, and so these really are from my own life as a physician. So the first story, is a woman who is 94, and she ended up dying after deciding not to have cancer treatment. At 94, she said, "I don't know that I can go through all the effects of having to go every day to radiation." She had no family, and she described her friends as professionals. So it was the doctors that saw her, her lawyers, her caregivers, and that was really her community. And a week before she died, she ended up telling her friend that she felt very alone. Now the question for all of you, is if she's lonely or is she socially isolated? The next case is a 102-year-old man who ended up dying of something that unfortunately we call in the hospital failure to thrive, which is a really annoying diagnosis. It's a really fake diagnosis, which really is not getting at the actual issues, but really it often is a failure of social services and what's going on in people's community. And really it's a lazy response that as physicians we say because we don't want to delve into the problem, so we just call it failure to thrive. But he ended up dying in the hospital because he really didn't have enough support at home. He did have family, but they all lived out of state. He had a physician who saw him at home, and that was me. And he had incredible neighbors who helped to make sure that he was doing okay. But he did end up dying in the hospital, which was not his wish. So the question is he lonely or is he socially isolated? And the last case is an 82-year-old woman who died at the age of 82. She was actually pretty healthy. She did have arthritis, which was one of her biggest limitations to leaving her home. But beyond that, she didn't have many medical conditions. She had 4 children in the area. She had several grandchildren. She had frequent social engagements. And she, again, had 24-hour live-in help that she was able to afford on her own. So the question for you, is this someone who's lonely or isolated, and do we need to worry about her? So what do we actually call loneliness? How do we define it? So loneliness is the subjective feeling of being alone. And what's important here is that I can't tell you if you're lonely. You have to tell me, so it's important that we be careful and not make assumptions about how people are feeling. The other thing that's really important to know is the actual distress that people experience between what we would say the discrepancies between ideal and perceived relationships. So it's what is actually going on in your life, what do you want to be happening in your life in terms of relationship, and it's what's missing in between in that distress that causes the feelings of loneliness. Now this problem, this idea of distress is at really the core of loneliness and why it ultimately affects our health. I think many people, if you hear the word loneliness, it causes or it makes us feel an innate response, because I think everyone identifies in some ways, either because we've experienced it in some ways or we think we know someone who is experiencing it. Now, in contrast, social isolation is something that is more related to the number of relationships that people have. So it's quantifiable, and it also can be something that it's really about the lack of contact with the society or near lack of contact with society. Now, it's important to make these distinctions because what you'll notice in the media or in the literature is that these terms are used interchangeably, but they actually mean different things, and how we tackle the problem is going to vary depending on what we're looking at. So they can coexist, but we can have people who are isolated and not lonely and vice versa. So we've all heard the expression of feeling lonely in a crowd, and so I won't say I'm lonely right now. There's a lot of you around here. I'm feeling pretty connected, but it is something that happens, and so we have to be aware of that. So how does someone really enter into loneliness? So this is a little bit of a complicated slide. It also comes from the Campaign to End Loneliness. As Stephanie mentioned, the work in the United Kingdom is really phenomenal, and it's a model for all of us here in the United States to really do great work. But the way we can think about it is loneliness being the core emotion, and there's things that are happening intrinsically within us. So it could be what our personality has been our whole life. So it could be that we have been prone to or always experienced loneliness our whole life because of our personality. It could also be our psychological response. So how do we deal with uncomfortable situations or stressful situations or feelings of discomfort in a crowd? So that's another thing that can affect us internally in terms of how we experience loneliness. And then what happens extrinsically, so outside of ourselves, are the different risk factors. So it could be that you've had life events or traumas, you've had a recent loss of a spouse, you've recently retired, you've moved to a new city, all those things that ultimately could affect how we experience loneliness. And then there could be environmental factors. For example, living in a rural environment where transportation isn't as easy and you can't get to groups, or you live in a city like I do in San Francisco where there are a ton of hills, there's a lot of stairs, and that is making you have more difficulty connecting with other people. So those are the different ways that we can ultimately experience loneliness, or that makes us at risk for having loneliness. So why does this actually matter today? So I think it's not a surprise to anyone that we're all aging as we speak. And what we see internationally is that the population is growing at the same time that our fertility rates are going down. So in many parts of the world, fertility rates are what we call below replacement, meaning that people are having less than 2 children, which means that our older adults are getting older, and we're not having younger populations to replace. So there's huge demographic shifts. And as Vicki mentioned, I work internationally, and so what I've seen in other parts of the world, for example in Mexico, is that we are seeing public health systems that have been prepared to work with younger adults, children, infectious diseases, and suddenly we have people that are living older with chronic illnesses, and there is no infrastructure to take care of them. And we have no knowledge about how to do this. So really what we're looking at is a growing population of older adults without an infrastructure, and realizing that there's health effects of multiple social conditions that are affecting people's longevity and whether they can live independently. So what's happening here in the United States? So we know that the population of older adults over 65 has increased almost 20% since 2000. And we also know that in terms of life expectancy, when you reach 65, you still have an average close to 20 years of life expectancy, which also makes us think about the average age of retirement and how many years you have post-retirement without that community of work. Now, some people view aging as a positive thing, some as a negative thing. My mother will often say, I didn't sign up for aging. What's this all about? I don't know that I'm ready for it. But it really makes us think about our assumptions about aging and what we're doing and how do we think about the age as we get older. The other thing that we're seeing in our country is demographic shifts in terms of race and ethnicity. So a large proportion of older adults is also growing in terms of our ethnic and racial minorities in our country. And then other things to think about are who are living alone. And women particularly have high numbers of rates of living alone. So in terms of loneliness, and Stephanie mentioned some of these statistics, but we know that at least across the country, close to 30% of non-institutionalized, so meaning people who are living independently at home, are living alone, so close to 30%. And then in terms of the prevalence of loneliness, in my own study, we found that slightly over 40% of people in this country report some degree of loneliness. So pretty large numbers that we're talking about, and again, this is why we're really talking about this as a pandemic. If you look at studies from the United Kingdom, they break up their rates of loneliness a little bit in terms of severe loneliness versus episodic, but still we're looking at rates close to 30% and chronic, severe, everyday loneliness around 2%. So, and this is also, there's obviously things with reporting bias in terms of is someone likely to report feeling lonely because of the stigma we associate with it. So why are older adults different from younger adults, and why do we actually have to think about the health care and the care of older adults differently? So as a geriatrician, we really think about someone's function as the center of someone's life and what's most important. So for me, when I think about my older adults that I take care of, it's really trying to think about, are they independent or not, and what are their risk factors because of that? So this is different than what we're taught traditionally in medical school. So in medical school, unfortunately, usually the way I would talk about someone is that this is an 82-year-old person with diabetes, hypertension, blah, blah, blah. But for a geriatrician, the way I describe someone is this is an 82-year-old person who is independent at home, able to walk, etc., and, by the way, has diabetes and hypertension, which are like the secondary things. In younger adults, function, what affects function is what's happening in the family life, in the medical life, cognitive, emotionally, environmental, and financial. So these things affect function to some extent, but what happens in older adults is that all these domains affect someone's function much more significantly and all intertwined. So what happens is that if we ignore one piece of the puzzle, we are really ultimately missing ways to impact someone's ability to live independently. And this is why, for issues like loneliness and what's going on in the social sphere, so important. And the problem with our medical traditional education is that we don't focus on this enough. So the question for all of us now is, given what we're learning about the epidemic or the pandemic in our communities, are there cases of people who are experiencing loneliness that we are not identifying? We're either not identifying because we're afraid to ask, or we're not asking, and because there's a huge stigma around this topic. In San Francisco, we have a unique area as well because we are one of the urban areas in California with the largest proportion of older adults and people living with disabilities. And close to 20% of people are living alone. Again, because some of the challenges of the city were literally, in my practice where I see homebound seniors, I have people that are homebound literally solely because of stairs. They can get around inside of their apartment, but they cannot get out because of stairs, and we don't have the infrastructure and the programs to be able to get people out of their homes. So huge problem there that we're seeing. So because of our failure to identify loneliness, the question is, are we missing ways to identify and prevent functional decline and death, and should we be worried? So thinking about these three cases that I started with, should we be concerned about them? So start thinking about them, because I'll quiz y'all at the end and see what you think about this. And who would you be most worried about? Is it the 102-year-old who was living alone but died in the hospital? Is it the 94-year-old woman with cancer who had professional friends? Or is the 82-year-old woman who has 24-hour live-in care and lots of family around her? So who should we be worried about, or should it be all of them? So we'll come back to that. So a couple myths about loneliness, and I think this is one of the key parts of the talk here, is that though loneliness is very common, it is not a normal part of aging. So it is a very common human emotion. John Cacioppo, who does some of the great work in the field of loneliness, really talks about kind of core values for humans and for people. And one of those values and one of those basic needs are the feelings to belong. And this idea that because of this intrinsic need, when there are feelings of loneliness, that can be incredibly distressing. So even though it is a core basic emotion, it does not mean it is a normal part of aging. And because of that, we really have to think about our older adults and remember that at the core of all this is our ageism and our problems with not placing importance on older adults and realizing or thinking that, oh, it doesn't matter, they're old and lonely and we need to forget about them. So it's important to really remember that, and unfortunately this is not something that's well understood. The other thing that it's important is to note that loneliness is not the same thing as depression. When I first started this research several years ago, I was told by many mentors, like, don't study this isn't important, you're really looking at depression. And I proved them wrong, so I'm very happy I stuck to my stubbornness that I've had since a kid. But they can coexist. You can be depressed and you can be lonely, but it doesn't have to be that if you're lonely, you're depressed. It doesn't mean you have a clinical definition of depression. So important to notice that as well. The other thing is that the myth is that if you live with other people, you're not going to experience loneliness. And also, again, something that's important for us to realize, because it means that our solutions for how we deal with loneliness are going to vary, and it's not as simple as let's just go put you in a group home or whatever and forget about it. The other myth is that it doesn't exist in married couples, and I'll show you some numbers about that. I won't ask who's married, and my husband's here, so I won't say whether I'm lonely or not. But that's why I was here. I didn't want to miss him, so he came with me so I wouldn't feel lonely. And the last thing is that the last myth is that it will go away if you just join a social group. And that, again, is important as we think about interventions, that it's not always as simple, even though in my training in medicine, it's usually like if A, B, and C. So it's like if you're lonely, go join the senior center, and that's not going to be the right answer for everyone. It's going to be for some people, but we have to be careful with what we assume and what we're recommending. So again, driving in one of these points again is that there is importance in looking at both social isolation and loneliness, but remembering that just by being socially isolated, that does not ultimately lead to the same distress that people have when they feel lonely. So how can we identify loneliness? So there's quite a few different screening tools for this, but one of the most well-validated and well-known measures is something called the UCLA 3-item loneliness questionnaire. What's great about this questionnaire is that for everyone who works their busy lives and busy practice and in primary care where you don't have time for anything, having something that's simple is incredibly helpful. So what's great about this questionnaire is that it's literally just 3 questions. And the questions are, do you feel left out? Do you feel isolated? And do you lack companionship? What you'll notice about the questions here is that there's no mention of the word loneliness, and that's really purposeful because, again, of the stigma. Now, in my practice, I've done things a couple different ways. There are times that I will ask my patients directly, are you feeling lonely? And I'll see what they say. And sometimes some people come straight out and say, yes, I am, and this is what's going on. Other times that's not a feeling that they identify with. And I will go through the 3 questionnaires, and it's fascinating. I've had people that say, no, I'm not lonely, and then I go through this, and actually it turns out they are lacking in companionship and they are feeling left out. And so this is a great questionnaire. The way you score it, clearly the higher the number, higher being 9 is more severe forms of loneliness, and really a cutoff being of 6, so meaning that you're feeling these feelings at least some of the time, okay? It's very well validated in multiple populations, and the other thing to note is that it comes from a much larger questionnaire that was pared down and found to be just as valid as the larger questionnaire. So getting to the meat of this, how does loneliness actually affect our health? So I conducted a study in 2012 looking at just over 1,600 participants. They were people aged over 60. This came from a larger study called the Health and Retirement Study, which is out of the University of Michigan. And it's a fabulous database that really looks at the health and different kinds of outcomes in people in a nationally representative sample. We followed people over 6 years, and we asked them if they were lonely using those same 3 items. And what we were interested in is looking at if loneliness was a risk factor for death. And because of my work as a geriatrician, my ultimate goal is realizing and understanding what keeps people independent. So we looked at function in terms of activities of daily living and a couple other tasks. Now, the reason I came to this topic to study loneliness, so I'm trained as an anthropologist and in public health, and then I went to medical school, and my interest in health had always been about everything else that we don't learn in medical school, all the really important things that ultimately really affect people's health. And I was seeing in my own patients, well, what's making some people lose their independence? What's making some people move to nursing homes? Is that a choice, and is it a good thing or a bad thing? So I was starting to think in my own mind and in my own patients, what are the right things? And I was also noticing that I had, for example, I had one Latino woman in my clinic who all she wanted was a boyfriend, and she lived alone and really just didn't have access to a boyfriend. Unlike for many people where you think moving to a nursing home may not be a great thing, for her, it was like amazing. She suddenly met all these people. I mean, it was unfortunate that she realized that it was mostly women in the nursing home, but she did have a couple caregivers that were men, and so she became much more socially engaged and actually did much better. And I was like, why is that working for her? But for someone else, it's like the worst thing that could happen. So this is what really made me think about this topic. So the way we measure function, as many of you probably know, is looking at activities of daily living, which really are the basic activities of everyday life. Can people get dressed? Can they go to the bathroom on their own, etc. And then we also looked at upper extremity tasks. So are you able to raise things above your head? How far can you walk? And also difficulty in climbing stairs. So those are the things that, again, we were looking at in terms of function, in terms of independence. So the other variables that we examined, so this is a complex table, it's a typical research table, and what it shows you is that we looked at a lot of different measures: people's ages, their ethnicity, socioeconomic measures, living arrangements. And the couple points that I want to highlight here, and I'll just read it for you so you can see, that 62% of people who were lonely were married. Okay? So again, it's making us really think about our stereotypes or what we're assuming about people. The other thing I'll note that only 26% of people who were lonely were living alone. So again, the majority of people feeling lonely were living with other people. So it really makes us think about, what are we seeing? What's going on? Why is there that distress? Why is it that there's these discrepancies between the existing relationships and what people want? The other thing that's interesting here is 66% of people who were lonely were living in an urban environment. So this is also an interesting thing in terms of, we saw in some of the videos from the Campaign to End Loneliness that there are increased risk in rural communities, but there are just as much in urban environments. You know, my husband Josh and I, we used to live in a condo in San Francisco, and you know, you see people in the elevator all the time, no one says hello to you. And now we live in apparently one of the most dangerous neighborhoods in San Francisco, which we love. And we know more of our neighbors and more people than we did living in our condo. And the other thing I'll say is that my parents live in Southern California, and they come up to see us every month. And they've been a little bit wary of our neighborhood. They're slowly getting a little bit more used to it. But my mom now reveals that when we first moved, she cried, and she was really sad that we had picked such a horrible house. But now she's happy with it. But you know, they're learning to, she and my dad will go out for a walk. They'll go get a pedicure together, which I find amazing. And it's like my dad's new thing. And my mom is like, is it safe to go walk around? I was like, Mom, you just need to go say hi to people. And so last month, she went down, and she came back. She's like, it was amazing. I said hi to everyone. I was like, well, maybe not everyone, but... But you know, it's this sense of like, now like she knows the pedicurist, she knows the woman at the pupusa place, she met the homeless guy on the street, she bought a rose from someone. I mean, now it's like, it's a real sense of community, and here we are in the most dangerous city, but it's much more community than it was when we lived in our condo. So it's very interesting about what you see in urban environments and what can work and what cannot work. So what did we find in our study? We found that women were actually more likely to experience loneliness. I think there's some interesting things here that probably we need to delve a little bit more into in terms of, are women more likely to report and be honest about it, or is it a true phenomenon? And we also know that women are more likely to live alone, and that is a risk factor, even though it doesn't go hand in hand, but some things there. Non-white participants were also more likely to be lonely. They were slightly older, they were low socioeconomic status, and the other key point is that majority were not depressed. So again, thinking that we have to be careful in making assumptions about depression and loneliness. So what are the other results that we found? So again, we were looking at function as measured by activities of daily living, and we were looking at death. And what we found was that in people who were lonely, they had almost a 60% increased risk of losing their independence solely by reporting and feeling lonely. And similarly, in terms of risk of death, close to 45% increased risk of death by being lonely. What's important about this is if you think about research methods, what we do is we want to make sure, well, are we measuring what we think we're measuring? Are we sure it's not because they smoke? And what we did in the study is we really we took out all the variables that usually affect things. So not depression, not cardiovascular risk, not smoking. So it's independent. So despite all those things, it was an independent risk factor. So what did we find? Again, we found that loneliness is incredibly common. It is an independent predictor of functional decline. It is an independent predictor of death. And just from this, we know that we have a long way to go in terms of what we need to do from here. So potential mechanism, this is not my area of research in terms of what the pathways are, but there's a lot of theories around this and a lot of work being done, again, by some of my colleagues, John Cacioppo, for example. One of the main thoughts is that there's an increased stress response. Again, it's this distress. It's the idea that there's something missing, that you have this innate feeling of wanting to belong and that's not working. Some of the evolutionary biology theories say that because of this human need of wanting to connect, that loneliness in some ways may be a protective thing and that you feel lonely and it's trying to get you to try to join with another group as a way of protection. But so different ideas there, but again, likely that there's increased stress hormones and that's ultimately affecting our cardiovascular health. There's also some ideas that really, if there's increased loneliness, whether that's affecting our sleep, affecting our ability to engage with the medical community, it's probably bi-directional. So which one goes first? You're lonely, you don't go to the doctor, you don't go to the doctor and you're lonely, so which way does it work? And also if there's differences in how we care for ourselves if we're feeling lonely. So those are the different theories around there, but it's hard to really figure out what the causal mechanism is. So there's a relationship, but how exactly it's caused is very challenging to understand. So other results. So I want to also highlight that when my research was first published a couple years ago, my research was not the first. There's been a lot of work in this area of loneliness isolation. But what was important about my research was that it was the first time really that it was published in a medical journal. And again, I think that the issue is that this has been something that's been aware to the public health community, to the behavioral health community. But in medicine, we tend to be a little bit, blinded by the social factors and don't want to think about them. So when it was actually published in an internal medicine journal, it was the first time it was like, wow, this actually affects people's health. And since then, there's been a lot more research as well that's coming out in medical journals. So this is the same journal that my paper was published in, and this looks at cardiovascular health and living alone. So we're seeing really the effects. So I'm going to go through a couple examples of studies to give you a sense of how else loneliness is affecting people's health. So this one looked at really loneliness rather than social isolation as a risk factor for death in older men. This one looked at dementia onset in people who reported loneliness, and I'll tell you a little bit more about that. This was the combination, kind of the double whammy, that if you're both socially isolated and lonely, you have increased risks of death. And then recently, 2 years ago, looking at this idea of frailty, which we're also recognizing as an older adult syndrome, which is really a marker of the body not being as resilient, and whether loneliness is associated with frailty. So some interesting things is there as well. Once again, the United Kingdom is way far above us, but I like about this study, this was actually an intervention study looking at nurses intervening post-hospitalization to help identify and mediate loneliness. So some really good work being done there. And then one of the biggest papers in the last year also is looking specifically at the risk of Alzheimer's disease and loneliness. And the idea is that what they did is took MRIs of people who reported feeling loneliness and found a higher amyloid burden. Amyloid is the protein that we see in the brain with people with Alzheimer's, and so there's a higher burden there. And so the idea and what we're trying to understand as we learn more about Alzheimer's dementia is that are some of these things like loneliness, depression, and anxiety kind of precursors or a prodrome that we call to the onset of Alzheimer's. So a lot being done in this area. We still have a lot to learn, but clearly it's telling us that loneliness is affecting our physical health and our mental health in incredible ways. The bottom line, and this is my colleague Holt Lundstad, who wrote a fabulous paper and really equates the risk as loneliness in terms of our health as being equivalent to smoking 15 cigarettes a day. And I think this really helps to quantify what the risk really is. Okay, so it's not insignificant, and again, this is why you all are here, to spread the word and realize the effects that loneliness really does have on ourselves and our communities. So what's going on with public messaging in the community? So this was a really funny title that said loneliness can actually kill you. I thought it was a little bit extreme, but I think it was the whole point, as we the media wants to grab attention, that's what it did. Another one said, commented on my study that it should make you feel bad about not calling your grandparents. So it's kind of funny, but there is a part, the positive spin to it would say we need to stop ignoring older adults and we need to actually make a focus on actually connecting with people. Oprah had a brief campaign about saying hello to everyone. Apparently my mom listened and she's saying hello to the whole world now. And then the other thing that we see also, and this is the UK has been great in this, is thinking about unique populations. So we know that the LGBT population, as we saw in the video, is particularly at risk of loneliness because of other feelings of marginalization. So certain populations. In my work in the community, I also work at a federally qualified health center where I have a lot of immigrant groups and non-English speakers, and I see in some of those patients that they're experiencing both isolation and loneliness, and it can be really challenging to find good resources because of language barriers, and that's something that's really challenging. So thinking about your communities, what are the groups that are even more marginalized and more at risk that we're not identifying? So what can we do, and are there potential interventions? So the first thing, I'm hoping that we all learn that asking about loneliness is actually a really good place to start. It can be scary because we really have to be prepared for the answer. It's similarly to when we ask about depression and suicidality, we can be scared because we don't know what we're going to hear. And that can be really distressing for us. And we'll learn some about the community programs here, but some of it is actually learning some training on what do you do with this information when you learn. It can be very humbling, though, to learn what's going on and just by asking about it. My mom, it's very interesting. So I've been stubborn from birth. I won't ask my husband to comment if that's true or not, but I'm 38. I sometimes tend to think that I'm ready and I know everything. And, my mom will call me and give me advice, and she'll sometimes tell me to take vitamin C for a cold. I'm like, really, Mom? I'm a doctor. I don't need your advice. And I can be a little bit snappy with her. And, she told me recently in the last year, she said, Carla, it's really hard as I get older as a parent to know how I still have a role in your life and what I can provide value to. And I realized that it was such a humbling moment. And I realized that there are times that she's feeling lonely and she wants to feel connected and she wants to know that she has a purpose in my life. So that's been very helpful to me, so I can not be so snappy and realize that I still have a lot to learn, and she actually still has a great amount of things to teach me, and I just need to shut up sometimes and let her give me advice. And I would say because of that there is, as I was saying, sometimes you just need to listen. I do need to listen to my mom, and there are times that having someone say that they're lonely is just the first step. I participated in a group a couple weeks ago in my clinic, and it was a support group, and it was amazing because it was predominantly Black men. And at the end of the talk, I'm talking about loneliness, one of the gentlemen there who was in his 60s living with COPD, chronic obstructive pulmonary disease, and on oxygen, he said, I've never said this out loud, but I'm feeling lonely. And it was just such a powerful opportunity for him to actually say it, and then for us to listen. There wasn't any specific intervention at that point. I think the intervention was just creating the space for people to talk about it. This is a fabulous quote from someone who I've taken care of, who's a phenomenal and world-renowned blues and jazz singer who's going to be playing jazz or singing at SF Jazz on her 90th birthday in July. And when we asked her about how she combats loneliness, she said, if you want to avoid feeling irrelevancy, you need to maintain your friendships, maintain your family ties, and stay an active part of other people's lives in whatever way you can. And I think this is important in some ways how we think about interventions. And I have some people who don't want to say, I don't need the help. But maybe what you can rephrase it and say, well, maybe other people need your help, and that's a way for you to interact and maintain connections. Lots of campaigns going on internationally, and this is really, it's kind of a mixed bag in the sense that it's amazing that there's so much international attention being drawn to this, but it also means that it's because we have a huge problem. So it's positive and negative at the same time. But if you have time after this talk, really check out their website. It is phenomenal, the amount of resources they have, the videos, the stories, the interesting information they have on interventions and research. So I would really look at that website. But what's phenomenal about the United Kingdom is that they really have made this a national campaign. We're getting there in this country, but we're not there yet. The second thing I would say is involving the healthcare community and however you define that. We'll talk a little bit more about resources here in Oregon, but certainly we know that the ADRCs around the state, and specifically here, are a great first place to stop. I mean, it's a wealth of resources. I love going on the website and seeing what's actually available. Some of this information is also in your packet, so you can refer to it, but we'll talk a little bit more about specific programs. So ultimately, the challenge about how we manage loneliness is that it can be really challenging because loneliness is complex, and so we're going to expect that the solutions are going to be complex, and it's not a one-size-fits-all. But a couple ways to think about it in terms of a general approach are 4 different prongs. So we can think about one way in terms of, does someone need improvement in their social skills in terms of how to interact with people, and is that a way that we're going to be able to combat loneliness? The second thing is, does someone need increased social support, and is that a way to combat it? And the third, do we need to increase opportunities for people to be able to engage? And then lastly, addressing maladaptive social cognition, which I don't really like that term, but that's what's in the literature, so I put it up there, which is really our response to situations, to the distress. So because of this, it's really thinking about what helps you or what's helping others connect to other people. So if we think about, again, thinking about these different circles that affect our lives, so what could be going on in these different domains? Where do you fit in? Are you on the outside of these? And do you need to be more central to these and have your interactions affect you? Are you missing some parts of the circle? Are there areas that you don't have in your life that you need to expand? Are there other interests that you haven't explored in a while, and that's what we need to think about? My dad just turned 75, although I reminded him he started his 76th year. He retired a couple years ago, and that was a big shift for him. He had been a lifelong academic and had his university world at the center of his universe, and so it's been a big shift for him to know what to do with his life. But he is constantly developing new hobbies and new habits, and so that's really what's helping him be connected. So he 2 years ago my dad's a tall Italian man, and he bought a little Fiat 500, and he has a group of friends in Spain that said, we want to see the video to prove that you can get in and out of the car. So he can, but he just donated the car to us, so I think he's moving on to bigger cars. But he recently, he goes to Cars and Coffee every Sunday morning. That's his thing to do. He'll take his car and he'll go hang out with, a group of people, and that's his new way of engaging and meeting new people. So it's really neat to see what he's done for himself. But it's also thinking about, and for my mom, who's also retired, she used to work with migrant communities, and she's no longer working, so she's trying to figure out now how can she keep using her skills. She's a Spanish speaker. We have a large Spanish-speaking population in our town, and how can she continue to be a part of her community. A quote from our next speaker, which is one of my favorites, really, that ultimately it's about reminding people they're still part of their community, and that's what I do with my parents and with my patients, and we are working to encouraging caring connections because that's what binds us to life. So really, I think this quote from Patrick, who is a phenomenal person, one of my favorites, so you'll have great things to hear from him. But really, it really summarizes why we do this work and where we go from here. So thinking about how we utilize existing programs. So again, coming from the United Kingdom, so something called the Silver Line, and I'll talk about what programs we have here in the United States, but the Silver Line is a program really to connect older adults who are lonely. What's great about it is that it's 24 hours, 7 days a week, and as one of the founders said, loneliness is not just an 8 to 5 experience, and we certainly know that the night times and weekends can be particularly difficult times. So what's nice about the Silver Line, and we'll hear about our programs, is that you can call it at any time, and you can also schedule calls to you. Mather Lifeway is another program. I'm going to go through these quickly, but they're in your slides. Just I want to show you the resources and the different things we have in our country to help look at some of these problems. So Mather Lifeways is great because they have different programs. Senior Center Without Walls, one of my favorite programs also. So it's really for people who are homebound or home limited that don't have capacity or don't have the ability to get out. And they have all kinds of telephone-based programs, from support groups, from current event discussions, book clubs, and they have calendars that you can download that'll tell you, or you can print out that'll tell you what calls are happening on what day, and it's really neat. I actually participated in a call with them about 2 weeks ago, and it was actually a forum on discussing loneliness, and it was phenomenal just to hear how people were invested in this and what opportunities it gave them. Senior Companion Program here in Clackamas County. So this is a model that's around the country as well, and it's really amazing, again, because I think you see relationships it benefiting both people, those that are volunteering to be the companions and those that are receiving the companionship. So thinking about how we can use these resources, and I believe there's some information in your green folder about this as well. Get Trained to Help. So I really, I'd never heard about this program, and I was really fascinated to learn about this, and I think this relates to what we were talking about earlier, that it can be scary to ask about loneliness and ask about depression if we don't know how to respond. So programs like this can help anyone really learn to be those first responders and how to relate to or how to respond to crises and mental health problems. Leaving the information there on your slide so you can have them, but again, some resources for you and again in your program. Other online tools, and this is also in your packet. What's really great is that AARP is starting to take a national role in really thinking about how we combat loneliness and isolation on a grand scale across the country. So the program Connect to Effect is an online resource for tools, and also you can look up in your county or in your state what's going on in terms of resources available. So we're getting there, which is really exciting. What's also exciting with AARP is that in August, there's actually going to be a meeting with the National Academy of Sciences and AARP to really think about what are we doing nationally and do we need a national strategy. So we will catch up to the United Kingdom eventually to see what's going on. Other examples of what's possible, if it doesn't already exist in your community, think about whether this is something that you can start. So this program called Linkages is out in the Bay Area. There's different components to it, but one of the things that I like about this is that it's a way to match people with skills and resources. So it may be you have your profile and it says, my name is Carla, I know how to garden and I can water your plants, but I don't know how to sew. So perhaps you're going to sew for me when I need my pants hemmed, but I'm going to go water your garden when you're out of town. So it's a way to maintain relevancy and connection and offer services and get things in return. So it's a really neat program that's being done. The Friendship Line, and Patrick will probably talk a little bit about it, but the Friendship Line is really our equivalent of what the Silver Line is. And what's fascinating in the Friendship Line, it's been in existence since the 1970s, really specifically targeted at older adults. So there's a lot of crisis lines around the country. What's amazing about the Friendship Line, it's specifically for older adults, and the volunteers receive training specifically in older adults. The Friendship Line has a couple different components, so it's also 24 hours. You can call in at any time and get support. And there also is a program where people can get scheduled calls during the week, so that dual component, and it's about creating relationships. So it's letting people know that there's always going to be someone on the other line that's there, but it's also making sure that they have a way to connect. Other community programs, so again, different things to note. I'm not sure if you guys have the village movements here in Oregon. You do? Great. So started in Beacon Hill in Boston as a way to help people age in place, and with the same idea that you're trying to create a network of people so that perhaps I'm having surgery next week and I'm going to need someone to bring me groceries because I'm incapacitated, or you're going to have other social support groups. So models around the country. We do have some in San Francisco. I would say that phenomenal for many people. They have not been as successful in lower income communities, but I'm hoping that'll change. And there's some of the villages that will offer scholarships in a way to include people of lower socioeconomic status, but some things there. And again, this is about knowing what different types of resources may be available, because everyone's going to have a different response. So new platforms and research. So where are we in terms of technology? So the daily call sheet is another type of phone-based system. What I love about this program is this was actually started for the Motion Picture and Television Fund, which is in Los Angeles, and is actually for people who are retired in the movie industry, from all actors, cameramen, everything. And they call it the daily call sheet because it was the equivalent of when you were an actor and you had the daily call to see what you would go on casting for. So it's the same sort of thing to how to create connection. So I'm showing these examples to really show like how innovative we can be and how from an idea these amazing programs start. So think about what's missing in your community and what you can start or what we can leverage that's already existing. Technology. So I live near Silicon Valley, and I'm a little bit like technology inept sometimes. But I think that the way I think about technology, maybe because I'm not a millennial, so I'm not like super into it, I'm not sure, but I think there's some great positive things about technology because it can help us reach people, but it's not going to be the end-all be-all for everyone. So it's important to know that. I will highlight one product that I'm starting to learn a little bit about. I have no relationship to them, so no disclosures, but something called the GrandPad. And what I love about this and learning about it, that it was actually started by a family. It was a 20-year-old who started this, and he realized that his grandmother was the one who used to always plan the social events. And when technology started, she got left out of the loop because everyone was scheduling online, and she was getting left out. So they decided to create this tablet really focused on older adults that has calendar functions in a way, it has built-in Wi-Fi, so you can do everything in one thing. So they did everything from thinking about sensory function in older adults and how it'll change when you press the screen on a touch screen. So it's a really neat product. So these are the types of things that are really interesting to see coming out. We don't know yet which ones really work, but it's nice to see the technology starting. But again, it's this idea that it's not going to work for everyone, but knowing what's going to be out there as a resource. Ultimately where we are, and again thinking that AARP is really working nationally, is that the first step is really thinking about awareness. So are we aware of loneliness in our community? How do we reach people who are lonely? And ultimately, how are we going to make an impact, and what are our next steps? So where we are right now in the literature is really figuring out what works. What's challenging about where we are right now is that we have a lot of anecdotal evidence. So we know from the friendship line, for example, and we have from smaller studies that the friendship line really works. We also know programs like Caring Hands in the Bay Area, which is a program that helps give transportation to people and create connections. And one woman said that you have saved my life on more than one occasion. And I don't think this is really just about getting to the doctor's appointments. It's really about finding someone and a connection. And similarly, when I was on the call with the Senior Center Without Walls 2 weeks ago, one of the participants said, I literally don't know what would have happened to me if I didn't have this program. And this is the potential impact these programs have. But the problem with where the literature is right now in terms of interventions is that we don't have a lot of research in terms of what's actually working on a large scale so that we can say, this is working, let's scale it. And that's really where we need to go in terms of research. So thinking about our 3 cases. So the 93-year-old with cancer, lonely, isolated? Both? You guys are good. So she definitely was lonely, and it was something that she was not lonely in her earlier life, but it really became worse as she became more disabled and when she moved to her nursing home. What was challenging about her is that because of this disfiguring cancer on her face, I think that created some distance from people. It made it hard for her to engage with people. And she was probably isolated as well. Even though she had a small network of professionals, she still ultimately was very isolated from the rest of the world, and that created a lot of problems. And again, she was someone who did not do well in a skilled nursing facility, and it was really sad because she had devoted her whole life to living independently, but in her last few weeks she had to move because we didn't have many options. The 102-year-old with quote-unquote failure to thrive, he was isolated, exactly. He actually was not lonely at all, but he was very isolated. He had resources, but not enough, and that ultimately made him be in the hospital. He also cracked me up because he used to sell antiques, and I walked into his apartment one day, and he had this cabinet full of stuff, and it said, "For sale, inquire within." And I was like, well, no one comes here but me. I was like, is that a sign? So I did actually buy like these two like cocktail glasses, which I still use, and he was so thrilled to sell them to me. It was very cute. But those are the types of things also that I love about my work being a home care physician, is that you get to interact with people in different ways. And I also know that sometimes in my work, probably the biggest medical intervention is not checking their stupid blood pressure, but actually really talking to them and making a visit. And then lastly, the 82-year-old with family. She was incredibly lonely and not isolated. I mean, and she was one of my most challenging because she had everything around her, and yet she had deep, deep, deep feelings of loneliness. With her, in talking to her family after her death, there was a lot of things that probably had been lifelong personalities. She had been a socialite, but I think she was someone that was a socialite because that's what she did, but it wasn't something she ever felt comfortable with. The other thing that happened with her that really gets to these ideas of ageism and how we view older adults and our interactions is that she started losing her vision and hearing, and so she became very embarrassed and didn't want to go out anymore and didn't want to have people over for lunch or dinner. So these are the things that if we could create environments where adults feel safe and comfortable to go out with their hearing impairment, their visual loss, their memory impairment, like we would probably make an impact, and that's what we're going next. But challenging, and again, I mean, these are things that made me think about, like, I would have never thought she was lonely, and because I've started doing this work and really delving in, it makes me realize like what I'm missing in people. I do actually think that she died prematurely because of these things, so that's also something that's interesting to think about. Could I, if we had identified it sooner, could we have made an impact? It was also challenging because she probably needed a lot of work in terms of behavioral health to really think about and delve through some of her emotions, but she wasn't quite willing to go there, which was challenging. So our tasks ahead, where are we? Funding for research on loneliness, and it's really at this point not in terms of the epidemic or the pandemic, but really thinking about how do we intervene and what do we actually do? What's going to work and how do we scale? So Patrick and I are on a mission to really scale the friendship line and thinking about how do we really prove in concrete ways that it's working so that we can create a national program. So that's our scheming on the side. It's also funding new programs. So what's existing and what can we expand? So if I was queen of the world or president, which would be amazing, it would be really thinking about how do we partner with payers? How do we show the payers? How do we show the healthcare plans that really it's about helping people connect? Maybe they need in-home support services not for making their meals, but because it's for companionship. Is that what we need to do? There's a new program in California called Care More, which is taking high-risk Medicare, Medi-Cal patients, and they are starting a new program specifically to address loneliness. So I'm very intrigued to see what's going to happen. But that's where we really need to move the needle, so that's where we're going. Determining which interventions work, again, so we know what we can scale and what we can say, let's do this all over the country. And then spreading the word, and this is really why you all are here. So it's thinking about how do we reconceptualize aging, how do we make sure that we're not being ageist, and how do we identify older adults who are lonely, and how do we start to address it in meaningful ways. And lastly, it's also looking out for ourselves. Some of us may be experiencing loneliness ourselves and not admitting it. Some of us may have blinders and not want to see what's going on in our community. So how do we start to open our eyes and really reduce the stigma around this topic so we can talk about it openly? So in summary, I hope I've explained to you that loneliness is very common. It definitely affects our health both physically, emotionally, and cognitively. It is likely more distressing than traditional risk factors, which means for me as a physician, you know, it may be that I want to focus on diabetes and hypertension, but really what's bothering the patient is loneliness, and realizing that likely is going to have as big of an effect as their other risk factors. It's a risk factor for death, and I do strongly believe that starting to talk about loneliness, we can make an impact. And I do also think that there are ways for us to help older adults and all of us be more connected. Thank you.